Dr. Jeffrey Mechanick é diretor professor de medicina e diretor médico do Centro de Saúde Cardiovascular do Mount Sinai Heart Hospital em Nova York e ex-presidente do American College of Endocrinology. Vocês podem vê-lo acionando aqui o closed caption no Zoom. Tem uma teclinha aí que vocês podem ouvir, vai haver uma tradução simultânea de sua palestra, com um pequeno delay, obviamente, e a seguir nós teremos uma nova pergunta para o pool, e peço a todos que fiquem atentos à palavra. Jeffrey, we are all ears for you. Welcome again, and take your time.
Okay, thank you. Thank you very much, Marcus. Ricardo, thank you for inviting me, everybody else here. Thanks for having me. Let me pull up my presentation. There we go. And hopefully everybody can see it and hear me well. And I'm assuming that I'm being translated also. So yeah. Thank you. So what I'm going to do is speak about COVID-related cardiometabolic syndrome. This is something that has emerged. Just a second, having a little problem advancing my slides. I'm going to try it this way. There we go. Here are my disclosures. This is something that here at Mount Sinai, really a hospital that represents the epicenter of the epicenter within New York. We really got hit very hard, as everybody knows from the news, for COVID-19. And as a result of this being a very high volume hospital and myself having a high volume practice, we've been able to make a lot of observations. And then within the academic setting, working here with Valentin Fuster in the Cardiovascular Institute, there's been an academic complexion to what we do. So a nice bridging of the clinical and the academic to try to come up with some new ideas. What I'm going to present is this new formulation for cardiometabolic syndrome associated with COVID-19. We'll talk about COVID first, then talk about cardiometabolic-based chronic disease. This was a double paper that we published in JACC, Journal of American College of Cardiology, back in January, and then go into the specific COVID-related cardiometabolic syndrome, discussing three specific stages: pre-COVID, the acute COVID state where the patients are very, very sick and in the hospital and in the ICUs, and then something that we haven't really experienced yet. In a way, it's theoretical, but we all know that it's coming, this post-viral syndrome or post-COVID cardiometabolic syndrome. I'm going to also spend a little bit of time, if you don't mind, talking about bariatric procedures with respect to this cardiometabolic onslaught, and then we'll have some conclusions. So COVID-19 coronavirus disease, based on the SARS severe acute respiratory syndrome coronavirus 2, was described in an initial cluster in Wuhan, China, as we're all aware of. The median communicable period is reported at about 9.5 days. We have quarantines that go up to 14 days, but there are cases where patients are communicable up to 21 days. 80% of patients are thought to be asymptomatic when they have the infection, even though they can have a high viral load. The infection coefficient has ranged in the literature from 2.0 to 3.5. There are actually some reports that the infection coefficient could be as high as 5, maybe even 15, depending on the country and depending on some other variables. The infection coefficient is basically the average number of people that a single person would infect. And this is in the early phase. The case fatality rate is really a very formalized index of confirmed deaths over confirmed cases. It was originally reported at around 2.3. That's probably an overestimate when you consider that the number of people truly being infected, that means they haven't been tested, is a lot more. So with this denominator growing, the mortality rate overall is probably closer to 0.5%, which is pretty close to the 0.1% seen with influenza. However, when patients are in the intensive care unit, there are reports that this mortality rate can rise to nearly half. So it's pretty bad to end up getting intubated, going on mechanical ventilation, being in an ICU, and particularly if you're in the ICU for a prolonged period of time. And that's the stage that we're experiencing here at Mount Sinai, now weeks and weeks into this sort of peak, and we're dealing with a lot of patients with chronic critical illness. There is this disproportionate involvement of men over women. Median age is 57. Other series have placed that number a little bit lower. Comorbidities, not only cardiometabolic, hypertension, obesity, and diabetes, but there are other indices of chronic illnesses really associated with poor outcomes. But when you have hypertension, obesity, and diabetes, you really don't fare so well. And in various series, not only from the States, but from China, from Italy, France, and Spain, looking at the ICUs and looking at the mortality, then those patients who have died in the ICUs, you see this disproportionate increased number of patients who have had hypertension as high as 70%, obesity as high as the high 80%, diabetes maybe 50%, far higher than the prevalence rates seen in the population. And this is pretty consistent, and that's what's caused a lot of people to think that maybe this is a clustering. There's a unifying mechanism that underlies this epidemiologic association. The SARS-CoV-2 spike protein gets primed by a transmembrane protein, serine protease 2, and then it sticks right through, it binds this angiotensin converting enzyme 2, not the one that we're most familiar with, but the ACE2. And it's really a promiscuous protein. It's found all over the body. It's even found in the pancreas and on islet cells. And that's one of the reasons why in this acute stage when patients come in, not only do they have this cytokine storm, this hypercytokinemia, very high levels of IL-6 and insulin resistance, but also there's this destructive process of beta cells. So there's a decrease in insulin production, and that's why you see this decay-like picture in these acute presentations. The model of injury is really infection, inflammation, and thrombosis, and that's sort of what we work with. So you've just heard a little bit about chronic disease models. We'll talk about that. We'll talk about this cardiometabolic-based chronic disease, and this is sort of the template. This is the backbone of what's going on. And then you have a patient who gets COVID, and it just amplifies the process. What are the primary drivers for cardiometabolic-based chronic disease? Well, the most primary are genetics, environment, and behavior. But then you have key mechanistic drivers, metabolic drivers, which are abnormal adiposity, dysglycemia, and other metabolic syndrome traits. And we're going to spend a little bit of time focusing on abnormal adiposity. You notice I don't say obesity. BMI has not really been our friend. It has not served us well in a lot of the BMI-centric decision-making. I don't need to tell you, bariatric surgeons in the audience listening in and viewing this, that when we make our decisions solely based on BMI, we end up with problems. We end up with problems for just good clinical decision-making and the economics and reimbursement. And we really need to change the framework within which we optimally manage patients with this disease. And the same can be said about dysglycemia, where type 2 diabetes, frank type 2 diabetes, only represents really a terminal condition, terminal not meaning death, but terminal meaning in the spectrum, polarized all the way to one side, where it begins with insulin resistance, where you can have normal blood sugar levels, and then when you have effects on the beta cells, and the beta cells don't make as much insulin, then the blood sugars start to rise. They rise a little, and you have pre-diabetes. They rise a little bit more, and you have type 2 diabetes. And then the contribution of these other metabolic syndrome traits, vascular biology and thrombosis and inflammation, as well as hypertension and lipid disorders, all amplify the progression of this pathophysiology to cardiovascular disease. The main models of cardiovascular disease that find these metabolic roots are atrial fibrillation, cardiomyopathy, heart failure, whether it's HFpEF or HFrEF with preserved or reduced ejection fraction, and also acceleration of atherosclerosis with coronary heart disease. And as a result of this cardiometabolic-based chronic disease, when a patient then gets infected with SARS-CoV-2, the severity, SARS coronavirus 2 rather, the severity of COVID-19 can be a lot worse. So let's explore the adiposity aspect of this. In endocrine practice 2017, we published this paper, and we were really challenged by the fact that BMI just wasn't serving us well. It wasn't serving us well in clinical decision makings for a lot of the pharmacotherapy for obesity, and certainly the bariatric procedures for obesity. We are learning more and more about the adipocyte secretome, the chemicals and the inflammatory compounds that are manufactured in the adipocyte, whether it's leptin or adiponectin and other cytokines causing the inflammation. Also the distribution. If you look at South Asians and Southeast Asians, they can have diabetes at a much lower rate of adiposity. And in fact, they can even have a normal BMI below their ethnicity adjusted BMI of 22.9 being normal. And they can have this increased waist circumference and the visceral fat, the lipotoxic visceral fat. And in fact, they can have increased epicardial fat, pericardial fat, which is associated with higher rates of atrial fibrillation. They can have ectopic fat in the liver, and that's the whole NASH and NAFLD story, non-alcoholic steatohepatitis, non-alcoholic fatty liver disease. There was a recent description in endocrine practice about fatty kidney disease. You can have fat infiltration in the muscle cells, in the bone marrow. You can have abnormal fat with abnormal inflammatory M2 macrophages. So really, what we're talking about is not just an abnormal increase in the amount of fat, not just an increase in weight or BMI, but in fact, abnormal adiposity. So again, as bariatric surgeons and obesity experts, imagine a world where your clinical decision-making was actually based on the hazards, the biohazards of this abnormal adipose tissue, the complications based on this abnormal adipose tissue, independent of BMI, and that would sort of determine what drugs you use, how you intensify lifestyle, what bariatric procedures you use, how you can use hybrid procedures and hybridized procedures with medications. I think we're going to find that we're going to have far more effective care. And I should point out that the European Association of the Study of Obesity did adopt our adiposity-based chronic disease, ABCD for an acronym, our ABCD framework of obesity. The EASO adopted it as their formal position. And we're hoping that other societies also adopt it and we move away from this BMI-centric way of thinking. Now let's move on to diabetes. The same can be true for diabetes. If we just stick with saying type 2 diabetes is, for instance, an indication for metabolic surgery, what about all those patients with abnormal adiposity and insulin resistance, or all of a sudden the beta cells are getting affected? Wouldn't you want to intervene earlier if the structured lifestyle isn't working and if the approved pharmacotherapy isn't working? Imagine all the downstream volume of patients who would be healthier and not tax a healthcare system. That would free up so much money for other infrastructure for health and wellness within society. So we were prompted at ACE to put this model together because yet again, 10 years ago, there was a push to dispense with metabolic syndrome. Then again, there was a push to dispense and get rid of this whole notion of pre-diabetes. If you look at the DPP, a diabetes prevention program, it was argued mathematically that if you've invested all these dollars in the cost to treat people with minimal elevations in A1C that would predict or determine this diagnosis of pre-diabetes, you're really not saving lives. You're really not decreasing the area under the curve of morbidity or suffering. And it was argued that there was no role for it. But here's the problem with that line of reasoning. Number one, just because you diagnose someone with prediabetes doesn't mean you're going to intervene with a medication. There's lifestyle medicine. And in fact, structured lifestyle medicine and the branch of medicine that focuses on lifestyle is huge. We've just finished a second book on lifestyle medicine, on building lifestyle medicine centers. And this is something that we as physicians and healthcare professionals really haven't been trained well in. Forget about nutrition, but in exercise and behavioral medicine, there's a lot to do in terms of lifestyle medicine, and which doesn't really have the same cost factor that you find with pharmacotherapy. The second thing is that by having a diagnosis of prediabetes and even insulin resistance as part of a larger spectrum that encompasses frank type 2 diabetes, now you're recognizing a disease state earlier. And by recognizing it earlier, that means you can intervene earlier. That means there can be policy and protocol and education and culture within our healthcare environment of early and sustainable preventive health. Now, look at the counterexample. We wait. Patient comes into your office, their BMI is up, or they have an unhealthy lifestyle, but everything else is fine. They're metabolically healthy, and you wait, and you wait. You wait until the blood pressure goes up, or you wait until that LDL crosses a threshold, or you wait until they get their first step. Can you hear me okay?
Yes.
Okay, great. You wait and you wait until these detriments occur and this morbidity occurs, and you have excess morbidity, excess mortality, greater cost of healthcare, and you have a sick population. So by configuring these chronic, non-communicable diseases in a larger spectrum, providing the opportunity, exposing the opportunity for early and sustainable intervention, we've actually helped everybody else out at a population scale. Let's look at it another way. It could be argued that you could have abnormal adiposity-based chronic disease, but still have insulin-sensitive tissue, not have insulin resistance, not have hyperglycemia, but with more and more weight gain, you get the biomechanical complications, the non-metabolic complications, and parenthetically, still an indication as this gets worse and worse for pharmacotherapy and bariatric procedures. But then as soon as you get that beta cell hit with the macrophages and the cytokines and the apoptosis and all the other mechanisms where lipotoxicity directly affects beta cell function, now you get the DBCD, the dysglycemia-based chronic disease progression. What we did last year is we put all this together to build a much larger model of cardiometabolic-based chronic disease. We reasoned that if you have these primary drivers of genetics interacting with environment, interacting with behavior, there was a unique equation for every individual human being that set out some type of risk. And if you look at the paper in New England Journal of Medicine at the December 2016 by Khera et al., Khera et al., you saw that from an electronic health record, if you could classify patients at high genetic risk for coronary disease or low genetic risk, and then by populating that electronic health record with, do they smoke, what's their BMI, what's their blood pressure, all the modifiable risk factors. What you found was that patients at high genetic risk, if they adopted a healthy lifestyle, that relative risk dropped by about 50%. So a patient comes in and says, "Doc, I'm at high risk. Everybody in my family has died from heart disease. Why should I change?" Well, these data show the tremendous impact of behavior and environment and lifestyle change despite high genetic risk. So, since adiposity leads to cardiovascular disease, and since diabetes and dysglycemia lead to cardiovascular disease, let's put the cardiovascular disease in the same type of model. The two papers that were published, the first looked at the pathophysiology, the drivers. The second looked at what can we do about it. Is it just academic, or is there something we can do? In the first paper, we have 4 stages. Stage 1 is risk. Stage 2 is pre-disease, which means you have risk, but not the definition of disease yet. Stage 3, early disease. And stage 4, late disease. Now, frankly, this is what all of our medical systems are geared for, no matter what country you belong to. Your hospitals and these big monuments to healthcare we call medical centers, they're all dedicated to late disease, waiting and waiting and waiting, and very intensive and expensive care. But what if we could recognize and intervene at these early stages? What if we could convince our government, our third-party payers, the infrastructure of society, that we as healthcare professionals want to intervene early on, before the lifestyle becomes unhealthy, before the abnormal adiposity festers and gets worse, before you have insulin resistance and beta cells getting sick, before diabetes progresses and hypertension progresses, and before you get your first stent, and certainly before you get your second, third, and 10th stent. That's the concept here. And the intervention is primordial prevention to prevent risk, primary prevention in those with risk to prevent disease, secondary prevention in those with early disease to prevent later disease or a second event, and tertiary prevention, unfortunately, is what we're very good at. We wait, and we're very good at doing surgeries and procedures and chemotherapies and dialysis, but we all want to do things earlier. And for those of you thinking, gee, you know, I'm a bariatric surgeon, I'm more over here. Well, maybe not. Maybe some of these newer bariatric procedures that are non-surgical or less invasive would be more appropriate at these earlier phases, maybe to bridge, maybe as part of hybridized therapies. And that's why we all need to create these new frameworks to function in which better parallel actual physiology instead of using these arbitrary, unique, numerical surrogate markers. Remember, BMI came from insurance, life insurance, metropolitan life tables. It didn't come from something that was pathophysiologically based. Let me also mention quaternary prevention. This is the prevention of over-medicalization. This is ethical behavior, not doing unnecessary procedures. And obviously, by acting earlier and earlier, we are going to decrease the amount of medicalization. I include these two charts because of the cardiovascular outcome trials for medicines. Obviously, lifestyle and procedures, they could all have cardiovascular outcome trials as well. These are the medicines where there's a class effect for secondary prevention. We now know about DAPA-HF, the dapagliflozin used in patients even without diabetes, having a superiority, not just non-inferiority for cardiovascular disease, and also for renal disease, which just came out. These are our bariatric surgery guidelines published in late 2019, but also in early 2020 by multiple journals. And you can see here, we've included a lot of the non-surgical procedures in our guidelines this year, and we've anchored the discussion of bariatric procedures within this adiposity-based chronic disease and cardiometabolic-based chronic disease model. We have Francesco Rubino and the Diabetes Surgery Summit group. Ricardo, you were part of this. Many others on the call may have been part of this. And I bring up the stigma because, as you're going to see when we discuss COVID, what better way to decrease the risk of severity of COVID than to have a healthier population and manage the diabetes? Manage the obesity and the diabetes. But how are you going to do that if there's stigma? So this is all part of the social determinants of health, the stigma concept with obesity and really with being sick as well. This is really just amassing some of the data looking at bariatric procedures with cardiovascular disease. These are some of the principal studies looking not only at decreased risk of fatal cardiovascular events and total cardiovascular events that parallel the decreases in body weight, in remission of diabetes, but also the cost and the medicines involved with diabetes, these markers, these socioeconomic markers, which are very important and validate the procedure as having a place in our armamentarium. Phil Schauer published this terrific review, an annual review of medicine, looking at the 12 key studies looking at cardiovascular outcomes with the cardiometabolic-based chronic disease components, mainly diabetes with bariatric procedures. And you can see how these bariatric procedures really have a systems effect. So adiposity-based chronic disease is not just about adipose tissue, it's about the networking of all of our sick organs that develop over time and lead to this tremendous morbidity. Let's move on now to COVID-related cardiometabolic syndrome. It's a novel condition where the coronavirus infection amplifies the severity, morbidity, and mortality associated with cardiometabolic-based chronic disease. And the focus is on early prevention. Prevent the risks in the pre-COVID stage. That means now for everybody. It really meant a year ago, 2 years ago, but it's now for the future. We need healthier populations to prevent early morbidity and mortality in the acute COVID stage. So this is about how we use insulin in the hospital when in fact there are resource shortages and we may not have enough insulin, we may not have enteral nutrition pumps, we're running out of supplies, we need to protect our healthcare professionals so they're not going into the COVID rooms. All of the pumps, as you know, are outside the doors. We don't want everybody going in with insulin drips and checking sugars every hour. So we need to adapt our protocols. Here at Mount Sinai, we've written all new protocols for the management of these very severe hyperglycemic patients. And then prevent chronic disease in the post-COVID stage. This is emergent. We're learning about this now. Already we have patients going home and their hyperglycemia is still a problem. In fact, they're going through, some of them, adrenal withdrawal because they were on steroids. They have encephalopathy. They have cardiomyopathies. And this is an emergent syndrome that we're just in the process of witnessing. So the cardiometabolic risk, hypertension, as I mentioned before, and up to 50% of hospitalized and 73% of deaths attributable to COVID. Obesity, up to 48% of hospitalized patients and 88% of deaths attributable to COVID, and diabetes, 32 and 35% of deaths. You can look at it schematically here in the center part of the slide. This is the cardiometabolic-based chronic disease, but then COVID is amplifying these different parts. So you have COVID, you know, the adipose tissue may serve as a reservoir. There was a paper that just came out on that. A lot of theories on how patients with obesity, why mechanistically they're getting sicker. COVID attacking through ACE2 on the pancreatic islet cells and giving rise to hyperglycemia, the cytokine storm for the inflammation, the effects on thrombosis and hypercoagulability, on hypertension, and even the role of statins having pleiotropic effects with patients who have been infected with corona. And then corona directly affecting the cardiovascular system. There's still a lot of debate whether we're looking at inflammation in the heart or a cardiomyopathy or a viral infiltration of heart tissue. So there's a lot of interesting aspects from a pathological basis. And in our COVID-related cardiometabolic syndrome, there's going to be an acute phase and a chronic phase, no doubt. And we're going to need to be prepared and prepared in terms of the way in which we act. So early on, acting on the biological, genetics, and social determinants of health, behavior, discrimination, disparities in access to care, economics. These are all things. In the US, you probably saw in the press that ethnic minorities were getting affected a lot worse than some the higher socioeconomic strata Caucasians. And this is a social determinant of health problem that really needs to be addressed. Pre-COVID cardiometabolic risk mitigation. So prior to the diagnosis, that means now for a lot of patients still who haven't been infected, intensive lifestyle change, using the cardiovascular outcome trial medications, bariatric procedures. If you're dealing with someone who's got severe obesity defined in terms of their complications, address the social determinants of health, transculturalize, make it adaptable to that patient's ethnicity so they really understand what's going on when the healthcare professional is interacting. A formal cardiometabolic prevention plan, and there's a lot of debate now about just holding the SGLT2s because of the risk for ketoacidosis. Some people say to hold it early on if you're not infected. Other people say to start it even if you are infected. It's a lozenge for my dry cough. We have individual and population-based strategies. We should learn how to plan, build, and operate lifestyle medicine centers and reassurance telemedicine and restructure routines. Diabetes issues, to deal with the ketoacidosis, our blood sugar target is 140 to 180, and aggressive sub-Q insulin protocols. Do not feed with enterals if you're dealing with sugars in the 400, 500, 700 range. Bolus feeds if there are enteral pump shortages, and adjustments with steroids. The post-COVID syndrome, theoretical right now, would be about 3 months after the diagnosis. The transition to outpatient care needs to be protocolized. Weight loss, pharmacotherapy, bariatric procedural strategies. Again, intensive lifestyle change, addressing the social determinants and novel pharmacotherapeutics. And very importantly, an infrastructural change in the healthcare system for reimbursements and addressing these social determinants. We reviewed this yesterday on a webinar with scheduling now patients eligible for bariatric and metabolic surgeries or for follow-up surgeries. And really, this is based on the clinical correlates primarily, pushing these patients in and not having them stigmatized that just because it's obesity surgery, they should be deferred. Let me conclude. COVID-19 is more severe in patients at high cardiometabolic risk. Preventive strategies need to be formalized in all people in case of SARS-CoV-2 infection. Coronavirus infection, in those with acute COVID-19, and in principle, in those who have recovered. Tactical implementation of these strategies involves structured lifestyle change, pharmacotherapy algorithms, and appropriate and timely use of bariatric procedures. Thank you.